I'm Dr. Ken Landau. Thanks for watching. Let's talk about Diltiazem, or Cardizem as it was originally known. It was approved in 1982 by the Food and Drug Administration, and even though it's about 40 years old, it still remains in the top 75 prescription agents that are used in the United States. More than 12 million prescriptions will be written this year for the drug that comes in both immediate release, slow release form. It's a calcium blocker, and this calcium blocker, it's used to treat chest pain or angina, angina pectoris if you will. It's used to control the rate in atrial fibrillation and flutter, not to control the condition. It doesn't get you back to normal sinus rhythm, but it can reduce the ventricular rate, and it's used in the treatment of hypertension. Now, the calcium blocker family is divided into two groups. The dihydropyridines, which is amlodipine, and then the non-dihydropyridines, that's diltiazem and another one called verapamil. Well, the non-dihydropyridines have more negative effect on the heart rate and the force of contraction, and that's why these drugs, rather than the amlodipine, are used for chest pain, are used for the control of atrial fibrillation. They delay the conduction through the atrioventricular node. Electrical activity starts in the sinoatrial node in the atrium of the heart, the top chamber of the heart, goes through the atrial muscle and then goes down to the junction between the top part and the bottom part. We call that the atrioventricular junction. And at the atrioventricular node, the diltiazem slows the passage or slows the conduction of the electrical waves. So it slows the ventricular response. Sort of works like aspirin in an effect. Aspirin will bring your temperature down if your temperature is elevated, but it doesn't reduce your temperature if it's normal. Well, diltiazem pretty much brings the rate down if it's elevated, but isn't going to reduce it substantially if you have a normal heart rate. Now, there's a question about, well, what happens if you already have heart failure and your heart rate or your heartbeat isn't really forceful enough? You're not getting enough oxygenated blood to the tissues. Is the drug going to be positive or negative? Turns out it's mostly positive. So if you happen to have stable angina, you walk for 2 blocks and then you have some chest pain, some tightness in your chest, you stop walking for a few moments, pain goes away, you walk another couple blocks, comes back, do the same thing. That's stable angina, exercise-induced angina. But we also have another condition called variant angina or Prince-Meadow angina. It comes from spasm of the coronary arteries. Generally occurs while you're at rest, while you're sitting down, while you're lying in bed. Works good for that. Supraventricular tachycardia tends to come on without any apparent reason. All of a sudden your heart rate races, then tends to go away. Well, that's supraventricular tachycardia. Seems that this is a very good treatment. Atrial fibrillation, atrial flutter. You have really rapid ventricular heart rate. All of a sudden it comes on, or it could be present there pretty much all of the time. It seems that this drug, the diltiazem, slowing the passage of the electrical waves from the top part to the bottom part of the heart, seems to be quite helpful. Now, there's some atrial arrhythmias where it's not helpful, but for the overwhelming majority it is. And for hypertension, it's a first-line drug. Either you can take it by itself, or sometimes you add it to other medicines. It relaxes the smooth muscles that are lining the vessels, and it's especially good if you happen to have what we call low renin hypertension. Low renin hypertension, we get a hit of it because you have a low level of potassium oftentimes. Up to about 25%, 1 in 4 people with hypertension has low renin hypertension, more common in African Americans and the elderly. Sometimes a person has what's called a myocardial bridge. A myocardial bridge occurs when instead of the coronary artery sitting on top of the heart, they bridge through the heart muscle. And when they bridge through the heart muscle, when the heart contracts, it squeezes the coronary artery. And then when it squeezes the coronary artery, you don't get the full oxygenation going to the heart muscle cells because it's constricted. So as a result, you have some angina, that chest pain, maybe some shortness of breath, maybe you feel some pressure or tightness in your chest. Can occur in up to about 5% of adults. Another thing that the medicine seems to work very well for. The dose varies with the indication, varies with the reason you're taking it, whether you're taking a slow release or immediate release form, but it seems that there's a little bit difference in the pharmacokinetics between the different manufacturers. So it's probably a good idea with Diltiazem to take the same brand or the same generic brand all of the time instead of switching from one to another every month or so. Comes in multiple doses. The capsules and the tablets range anywhere from 30 milligrams up to 360 milligrams. It comes intravenous form too for appropriate indications of the atrial fibrillation or the supraventricular tachycardia, and it can be used off-label. So sometimes people develop hyperthyroidism. Well, usually in hyperthyroidism, we give you a beta blocker if your heartbeat is too fast. But some people can't take the beta blockers, maybe because you have asthma or some other kind of condition. The Diltiazem might be a very good option. Some people claim it works for headache prophylaxis, migraine prophylaxis, even to treat migraine headaches. It seems it also increases the pain-killing effect of morphine in animals without decreasing the respiratory rate. Decreases the development of tolerance to morphine, and also seems, at least in the rat model, to decrease the cravings for cocaine. Well, all of that probably works through the dopamine and through the glutamine in the brain. It also seems that the drug works for people who have painful anal fissures. It can be taken orally or it can be used topically. Topically, you can grind up the pill and put it in a cream base, put it in some Vaseline, or put it in some flow gel, which is just a special kind of base made of lecithin. Seems that it's absorbed better than if you just use with Vaseline, but seems to be a very good treatment. How does it work in angina? It decreases the oxygen requirements of the heart muscle, and by decreasing the oxygen demand, it can increase the exercise tolerance. So it decreases the heart rate, it decreases the systolic blood pressure at maximal work and submaximal work, it dilates the coronary vessels, increases the flow through the coronary vessels that are on top of the heart, the epicardial and the subendocardial vessels. It seems to inhibit the spasm, the spontaneous or the provoked spasm of the coronary vessels, and it also works on the peripheral vessels. So it seems to do quite a good job. Increases the amount of time that you can exercise before you have some pain. How does the medicine do all of this? Well, it's a calcium blocker. It prevents the calcium from flowing into the cells. It doesn't prevent the sodium channels. And by doing that, by working on the calcium channels, it relaxes the smooth muscles in the arterial wall, and that allows it to increase the flow. And it also works on the pacemaker areas of the heart. Well, if you take the medicine, very well absorbed if you take it by mouth. The bioavailability obviously is better if you get it intravenously. Has extensive first-pass metabolism when you take it by mouth, goes right from your mouth, absorbed through the gut, goes right to the liver where it's metabolized. Minimal therapeutic effect is somewhere between 50 and 200 nanograms per milliliter. That's how much your system requires in order for it to really work. If you take the Cardizem CD, the capsules, versus just the Cardizem tablets, well, we find that there's a greater than 95% more absorption with Cardizem CD, especially if you take it 360 milligrams. You're going to have detectable levels in the plasma within 2 hours, and it's going to stay at a peak level for somewhere between about 10 and 14 hours. There's no change whether you take it with food or whether you take it without food. Apparently, it's better to take any antihypertensive, but especially the Diltiazem, better to take it in the evening. It seems that if we do exercise testing and you take it in the morning, it's not nearly as helpful as if you take it at night and then do the exercise testing sometime in the morning. We know that most of the cardiovascular events, most of the heart attacks, most of the episodes of angina are going to occur sometime in the morning hours, especially between 7 and 11 a.m. And we find that if you take your drug at night, you'll have a greater reduction in the cardiovascular events, greater reduction in the death, than if you take it in the daytime hours, in the morning with breakfast, like most people do. Now, that's been a somewhat controversial subject over a period of time, but more people are beginning to accept that as we look at the circadian rhythm patterns of the different medicines and how they work. Well, for high blood pressure, if you take your diltiazem, it's going to decrease the blood pressure when you're lying down or when you're standing up. It's not going to cause a reflex increase in the heart rate. It's going to decrease the resistance against which the heart has to pump, and that means you're going to have better flow. So it's going to increase the cardiac output, going to increase the stroke volume, and it's not going to change the amount of adrenaline or noradrenaline, norepinephrine. It's not going to change the renin-angiotensin system. If you have good ventricular function, if the heart functions well, the negative effects are going to be minimal. It's not going to have any substantial effect. It's not going to reduce the cardiac output, reduce the ejection fraction. And if you already have ischemic heart disease, although we were worried that it might reduce the force of contraction, it actually seems to increase the exercise tolerance. So if we look at how the drug works, going back to taking it at night, it seems that there's a greater reduction in the diastolic blood pressure over a 24-hour period if you take your medicine, if you take your diltiazem at night. If we look at the systolic blood pressure, it doesn't seem to make any difference whether you take it in the morning or night. So you get the extra benefit if you take it at night. You get the benefit as far as the exercise tolerance, and you get the extra benefit as far as reduction in cardiovascular events. If you have the supraventricular tachycardia, it's going to slow the impulse generation at the sinoatrial node, and it's going to delay the conduction time at the atrioventricular node. So it's going to slow the ventricular response. Works that same way in atrial fibrillation. Now, there is a difference, because in paroxysmal supraventricular tachycardia, or SVT, or supraventricular tach, some people call it, it's going to convert your heart rate back to normal. If you have atrial fibrillation, it's just going to slow the ventricular response. If you take the drug orally, the half-life is going to be between 3 and 4 hours. If you take it intravenously, especially at higher doses, the half-life is going to be somewhere between 4 and 5 hours. Actually, if you take it intravenously, surprisingly, it's going to have a higher blood concentration and a longer duration of effect. Now, if you happen to have the atrial fibrillation and you're going to get the medicine intravenously, you need to be in a monitored situation. So you need to be somewhere where they have electrocardiograms that can monitor you, and you can have your blood pressure checked. You need to have a defibrillator and emergency equipment readily available just in case. Don't usually have a problem, but you need to have it potentially available. So the effect, if you get the intravenous injection, is going to occur within minutes. It's going to last for a couple hours. You get the original bolus, the first bolus intravenously, over a period of about 2 minutes, 20 milligrams. You wait about 15 minutes, and if the heart rate is still more than 100, you get a second dose, this time 25 milligrams on average, and then tend to, for the first 24 hours, give you some medicine just sort of on a routine. Get about 10 milligrams an hour over a period of no more than 24 hours. Several metabolites are present when you take it orally that aren't there when you get it intravenously. Now, if you get the medicine intravenously, we're going to be able to reduce your heart rate depending on how much of the medicine is there. So if we can get the concentration to, let's say, be about 80 nanograms per milliliter, we're going to be able to reduce your heart rate by about 20%. Reduce it by 30% if we can get the amount in the system up to 130 nanograms per milliliter. And if we can get it even higher, say around 300 nanograms per milliliter, we can reduce your heart rate by about 40%. Well, it rarely converts atrial fibrillation to normal sinus rhythm, but as I mentioned, in paroxysmal supraventricular tachycardia, it's going to get you back to normal sinus rhythm about 90% of the time. The medicine decreases your heart rate by at least 20%, more than 20%. In 95% of the people, and the response is going to be within a very short period of time. The maximum decrease in the heart rate is going to be about 2 to 7 hours. Rarely become hypotensive while you're taking the medicine. Once you get back to a relatively normal heart rate, it's going to last for about 7 hours on average, anywhere between about half an hour and maybe about 10 hours. We begin our maintenance therapy, switch you from the intravenous to the oral therapy after about 3 hours, and taking the Diltiazem on a routine basis by mouth now is a good idea, or maybe it's a beta blocker or quinidine or procainamide, or some people still digoxin. You should be monitored every once in a while if you're taking the medicine by mouth. Monitor it for the severity of the chest pain and how well it's controlling your angina. Check your blood pressure, check your electrocardiogram, check some blood tests. Those are all very common. Have to be cautious. If you have a sinoatrial or atrioventricular node disturbance, we have to be a little cautious about whether the medicine is really right for you. If you have a severe slowing already, we call it third-degree AV block, where the electrical impulses seem to be hung up or stuck at the atrioventricular node, the drug probably is not for you. And then the question is, well, what happens if you have reduced left ventricular function? So if the heart really isn't pumping out most of the blood, if the heart's pumping out, say, 35%, 40% of normal, normally it's supposed to be more than 50%, well, will it reduce the ejection fraction even further and cause you more problem? Overwhelmingly, the answer is no. Now, the drug shouldn't be used if you have really low systolic blood pressure. If your systolic pressure is less than 90, it's not for you. If you're cardiogenic shock, it's not for you. If you have an acute heart attack and you have pulmonary congestion on your x-ray, no, the drug's not for you. And if you have the sick sinus syndrome where the top part, the sinoatrial node, isn't putting out its electrical impulses, or you have the major problem with your atrioventricular node, or you have severely decreased left ventricular function, or if you have coronary obstructive, if you have COPD, or if you have severe peripheral occlusive disease, peripheral artery occlusive disease in your leg arteries, well, maybe not for you. Side effects of the drug? Relatively few, fortunately. Generally, the side effects are mild and transient. Some swelling of the legs in 2, 3, 4% of the people, headache in 4 or 5% of the people. Sometimes there's too much of a decrease in the blood pressure. People can become hypotensive, either with or without symptoms. The heart rate can slow in some people, slow a little bit too much. Sometimes people get dizziness or flushing or fatigue. Rarely you can have some bronchospasm, symptoms of asthma. Sometimes the liver function tests show some abnormalities, usually not particularly severe, usually not enough to stop taking the medicine. Sometimes people have allergic reactions or abnormal dreams or amnesia or tinnitus, but more commonly the side effects are, as with most drugs, including the placebo, nausea and vomiting and constipation, and sometimes people develop some shortness of breath. An interesting event that can occur is something called drug-induced lupus. Now, drug-induced lupus occurs with some muscle and some joint pains and some flu-like symptoms, some fever, fatigue, some inflammation around the heart or lungs, and a rash can develop. Well, this is one of the more common causes of that, along with hydralazine and procainamide and isoniazid and minocycline. Rarely we're going to have a profound slowing of the heart rate with the conduction delay that might lead to some dizziness or lightheadedness or fatigue. And sometimes people have some worsening of the arrhythmias, If you overdose on the medicine, well, it can cause really a severe slowing of the heart and a block at the top to the bottom chambers in that atrioventricular node and congestive heart failure and hypotension. For the most part, if you do overdose on the medicine, treat it in the standard way. Maybe you get a little positive inotropic agent, maybe you get a little atropine. Rarely ever need a pacemaker. Is it safe for pregnant women? Well, it hasn't been studied. Animal studies showed that there's some adverse fetal effects, decrease in weight, some skeletal abnormalities, can be lethal to some embryos and the fetuses in animal models. Now, some women have a condition known as hypertrophic cardiomyopathy. And if a person has a hypertrophic cardiomyopathy, this would be a standard kind of a medicine. And if you're receiving the diltiazem for the hypertrophic cardiomyopathy and become pregnant, yes, continue the medicine, but just have extra close monitoring of the pregnancy. The medicine is excreted in the breast milk at serum levels. So we don't recommend breastfeeding in people who are taking the medicine. Pediatric population, it's not studied in the geriatric population over age 65, tend to begin at the low range of normal, but we get basically the same response as with younger individuals. But interestingly, there's something known as the Beers criteria, B-E-E-R-S, and the Beers criteria suggests certain medicines are inappropriate for the elderly population. Diltiazem is on the list. It interacts with a variety of medicines, so that you have to be careful, because if you're taking a medicine that already is going to slow the heart rate, cause a bradycardia, then you have to be extra cautious about combining the two. So if you happen to be taking a beta blocker like propranolol, going to increase the concentration of propranolol by about 50%, cause considerable slowing of the heart rate. Or clonidine, basically do the same thing. Amiodarone, boy, that's not a good combination at all. And if you're taking a drug that's going to interact with the drug-related enzyme known as 3A4 that's produced in the liver, that's how many drugs are metabolized through this 3A4, CYP3A4 is the official title, well, you risk some toxicity because the diltiazem can build up in the system. So you've got to be careful if you're going to have anesthesia. Tell the doctor about that, because the anesthesia can decrease some of the conductivity. It's interesting, if you take either triazolam, which is halcyon, or Versed, which is midazolam, that's going to increase the concentration of diltiazem by about 3 or 4 fold. So that's a no-no. And with the statin drugs, so many people take the statins. Well, with lovastatin, it's going to increase the concentration of the lovastatin by 3 to 4 fold. The simvastatin concentration is going to increase by 4 or 5 fold if you happen to be taking diltiazem. So if you happen to take the simvastatin, you should limit the dose to about 10 milligrams if you're taking the medicine, this diltiazem. There seems to be no problem if you're taking the pravastatin. Have to be careful about diltiazem because it increases the concentration of buspirone by about 4-fold, increases tegretol concentration by about 40 to 70%, increases the quinidine by about 50%. Not good idea with fentanyl. Have to be careful with lithium and theophylline and prednisone. If you take Tagamet, it's going to increase the concentration of diltiazem by about 50%. If you happen to be taking cyclosporin, you're probably going to have to reduce the dose by about 15 to 50%, reduce the dose of the cyclosporin, and monitor the cyclosporin. If you happen to be taking rifampin, rifampin is going to make the diltiazem basically just disappear from the blood. It's metabolized so quickly. It can interact with aspirin. Have to be careful with the nitrates, either short-acting or long-acting. And even grapefruit or grapefruit juice can increase the concentration of the diltiazem in the blood. Well, diltiazem floats around mostly bound to different kinds of plasma proteins, either the alpha-1 acid glycoprotein or the albumin, but it doesn't displace other drugs that are also bound to those particular proteins. So it doesn't mean that you're going to have a higher concentration in the blood, let's say, of dilantin or hydrochlorothiazide or warfarin. It's extensively metabolized in the liver. It's going to be excreted in the urine and the bile. Even a little bit is going to escape unchanged in the urine. If you have renal insufficiency, you don't have to change the dose. If you happen to have cirrhosis, well, you're going to have an increase in the concentration because the liver is not going to metabolize it, so you have to be extra cautious. We have a problem right now with the intravenous form in the United States. It's expected to last well into 2020. At the present time, the pharmaceutical houses, the manufacturers, are just out of the drug. So right now, that's the story of Diltiazem, or as originally known, it's Cardizem. It's inexpensive, it's a very useful member of the calcium blocker family, helps prolong the amount of exercise you can get before you have the onset of chest pain from angina or from coronary artery disease. It can help spasm if you happen to have princemetal angina or variant angina. And in addition to all of this, it seems to be very helpful for slowing the ventricular rate in people who have atrial fibrillation. And of course, on top of all of this, it's a pretty good treatment for high blood pressure, and it has relatively few side effects. So definitely one to consider for the appropriate indications. Thanks for watching. If you enjoyed the show, please tell a friend and consider subscribing so you'll be notified as we post new videos. Appreciate your interest. I'm Dr. Ken Landau.